The objectives for this learning module are to differentiate forms of euthanasia and assisted death, and to discuss ethical arguments for and against euthanasia and assisted death. The topics covered include 2 articles. First one by Lowe in 2013, Physician-Assisted Suicide and Active Euthanasia. This article is important in discussing definitions of different types of euthanasia and the ethical reasons for and against the various types of assisted death or assisted suicide. The second article in this issue deals with the Oregon Experience by Dr. Volker in 2007. The Volker article provides an overview of the Death with Dignity Act that is legal in Oregon and Washington, and the nurse's responsibilities within this law. And even though this act is only legal in several states, the role of the nurse described by Volker is helpful to understand because it sets precedents for the nurse's responsibilities in other dilemmas, such as in pregnancy termination. 2 critical considerations in discussing assisted death include the individual self-determination, the right of the individual to decide what will or will not happen to his body, and protecting that right to decide must always be a concern for the nurse. The issue of consent is critical, not merely the right to decide, but the competency and ability to be informed of and to understand all aspects of the decision, and then having the uncoerced right to decide yes or no. This is critical. In society, all healthcare providers are ethically bound to protect those who may be vulnerable to coercion regarding an end-of-life decision. It is important to understand that withholding or withdrawing medical interventions are another type of care, as we have discussed it previously in class, is done if and when requested by a competent individual or a designated surrogate. And withholding and withdrawing is seen as allowing to die and is viewed legally and ethically as different from the types of interventions that we will talk about in this video. It is critical that we use these terms carefully because this is such an emotionally charged topic. Assisted dying, or abbreviated AD, is a broad term that encompasses both assisted suicide and euthanasia, and is synonymous with any assistance from a healthcare provider to hasten or augment the dying process. Suicide has a legal definition that in essence is the deliberate taking of one's own life that is arranged by the self, by the individual, for the specific purpose of death. This is of course separate from our discussion here of assisted dying as a result of health-related reasons. Active voluntary euthanasia occurs when a physician or other designated or selected agent actually administers a drug or device at the patient's request, knowing that administration will result in the individual's death. This is a process in final terminal hospice care when at the patient's or family's request, as part of an agreed upon end-of-life care, some type of sedation is administered slowly to induce deeper and deeper sedation, which will ultimately result in death. It is critical that there be agreement on this type of activity to prevent harm to vulnerable or non-competent individuals. But this is where the physician or a designated agent actually administers or does something. In contrast, assisted suicide, or the newer used term assisted death, occurs when the individual does something, swallows pills, activates a device, turns off equipment that has been provided, made available by the physician. So the individual provides resources, but the physician provides resources, but the individual himself must activate or be the agent. This is the procedure in the Death with Dignity Act that is legal in Oregon and Washington. The physician supplies equipment or resources, but the individual must himself administer or do something. Terminal sedation, or sometimes called palliative sedation, is a term associated with end-of-life discussions and is a deliberate administration of drugs to produce deep sedation in individuals with intractable pain or to relieve suffering during the final active dying process. Brain death is a legal term, and it is included here because you need to be familiar with this definition. It includes 3 criteria: absence of consciousness, no spontaneous respiration, movement, or response to deep pain, and the absence of EEG or brain activity, that is a flat EEG when measured on separate occasions. The Lowe 2013 article identifies specific ethical support for assisted dying. It is important that you be familiar with what is considered support for this practice. The 2 critical supports: respect for patient autonomy. The individual chooses not to experience pain or suffering that is predicted in view of a specific diagnosis. This is a rationale for the ethical support of the decision by Brittany Maynard, the 29-year-old woman in Oregon who has elected to end her life in early November to prevent extreme pain and suffering because of her inoperable brain tumor. So the second principle, supporting an individual's decision to participate in assisted dying, is beneficence. The benefit that would come to someone who is suffering extreme pain or immobility, and the greatest good would come from a relief of that suffering. The benefit then is a peaceful and dignified death on the individual's own terms at the individual's time of choice. But Lowe also briefly describes primary arguments against assisted dying, and it is critical that the nurse advocate for the individual to ensure that the sanctity of life is preserved, the fact that a vulnerable individual is informed and protected. Society has always worked to preserve all life at all costs, and this does need to be a consideration. The nurse must also ensure that there is quality care to ensure that pain is relieved and support measures are maximized, to perhaps relieve some of the pain and fear that may be driving the individual to believe that death is the best option. Many times, pain in terminal situations is not well controlled, and if it were well controlled, the individual would deal with the end of life differently. The nurse must also be aware of the possibility for abuse and must advocate that there be no abuse of this process through paternalism or victimization of someone who may be vulnerable, may not be totally competent to make that completely informed decision. The third of Volker's articles on end-of-life issues that we have discussed centers around her 2007 article, The Oregon Experience with Assisted Suicide. And in this article, she presents an overview of the Death with Dignity Act in Oregon, discusses the position statement from the Oregon Nurses Association regarding nurse participation in this activity, and discusses some implications for the Death with Dignity Act in other states. To emphasize understanding, Volker's articles concentrate on the overview, in which she describes what is required of the patient and physician, focus on the patient requirements to engage in this, and the physician's responsibility. Also, focus on Table 1 of the Volker article, page 154, for the nurse's role. If the nurse chooses to be involved, what she may and may not do from an ethical perspective if she chooses to be involved in an assisted dying situation. Also review Table 1 for the nurse's responsibilities if she chooses not to be involved, what she may do and may not do if she chooses not to be involved. This is critical to understand these roles and responsibilities. I wanted to include a brief word about spiritual issues in end-of-life care. Silence or hesitancy to discuss ethical issues in end-of-life is not desirable or helpful. All aspects of end-of-life care have different religious interpretations for everyone. Your role is to serve as an advocate for whatever spiritual support the patient indicates would be beneficial, and to support that family and patient through the natural process of dying. And remember that in any discussion of end-of-life issues, effective palliative care, that early identification and treatment of pain or other distress, may be able to support an individual so that the request of assisted dying is not necessary or could be postponed, and then that hospice care could effectively support the individual and family through the active dying phase. Through all end-of-life issues, remember that the role of the nurse is to assist the patient in this process to a peaceful end of life, a peaceful death on that patient's own terms. As you prepare for this exam too, review the study guide to ensure that you are familiar with the targeted material in each of the assigned articles. Thank you.